Thank you all for hanging around. This is very exciting to conclude this conference with what I think will be a very interesting and pertinent topic, and that is consolidation. Thanks as always to Margaret and Paul for this really forward-looking and enduring conference. It's always enjoyable for me on occasion to participate here. I feel like I got to emerge from the muted shades of semi-retirement back into the sunlight and glare of healthcare in its sad reality. So today we'll see if we can make some sense of this topic. To close this conference, we have, I think, a fascinating topic, and that is consolidation. Those of us that have been around in healthcare for 40 years have watched the advent of increasing consolidation, and I think it's a lot related to learning how to play Pac-Man on our Ataris back a long time ago. So we're going to hear from a lot of folks that have been really seriously involved in this venture. Just a back side note, I remember back in the early days when Healthcare Partners started to do a little bit of this merger consolidation. My old and dear friend Len Schaefer, who many of you know, a dear friend except when we were negotiating our Blue Cross contract, talked eloquently about the diseconomies of scale and how this was really a bad idea. And that was about 6 months before he went crazy with building Blue Cross and Anthem into the company it is today. So there are pros and cons of this consolidation story, and I think our panel here is well versed in what some of those are. So let's think about this. We have just as some examples, Anthem, Cigna, Aetna, Humana, Centene, HealthNet, Providence, St. Joe's, Memorial, which you'll hear about today, Sutter, Banner, Optum, DaVita, ChenMed, just to name a few of the active participants in what is a true consolidating story. So what drives it? And I think that's what we're hoping to learn today. Is it all about CEO ego, negotiating leverage and strength, forming oligopolies? Everyone else is doing it, why not? Can't make it anymore as a small guy in this heavily regulated world. We got to do something. Or maybe, just maybe, potentially what the stated objectives are, which we hear from each and every time we see in a consolidating entity, and that is we want to improve care to the patients we serve and do it cost efficiently and be patient-centric and have a switch from volume to value and make for our world a better, more cost-efficient, higher quality healthcare system. So do we actually get economies of scale? Do we actually get more efficient access to capital for technology and technology integration? Do we actually find the ability to cross that hard bridge? And I hope we hear about that from volume-based systems into value-based systems, and how do you make that conversion, that cultural conversion? And actually, do we see better patient outcomes and higher value for the dollar spent? Those are the kind of questions that I hope we will probe deeply, that you'll sharpen your pencils and be ready to ask probing hard questions of this intelligent set that you're about to hear from. And be ready, because at the end we hope to have some time for questions, and we'll be asking you to participate actively with our participants. But first, let me turn it over to our first panelist, Sam Glick, a partner in Oliver Wyman Health and Life Programs. Sam has been author of several recent Oliver Wyman points of view, including a $1 billion decision, charting a new course for U.S. healthcare. He writes on benefits and private exchanges. Previously, Sam was a high-tech strategy advisor at Accenture. Prior to that, did business and strategy and merger acquisition at Mercer. So Sam is well-versed in this topic, and I look forward to hearing Sam's comments for about the next 18 minutes, Sam. Okay. I hope so. Yeah, there's a clicker here. I suppose that works. There you go.
Thank you, Bob. Now, I want to warn folks, because usually being the kickoff person for consolidation, people just want to sit there and trade stocks on their phones about which deals I think are going to work. And I want to remind people that 80% of M&A deals across industries fail. And so we should think about whether this is the right solution is one thing, but I think there are going to be huge impacts from consolidation. Since I only had 18 minutes, I decided we'd do 6 trends. 6 trends that I think the other speakers will hit on. I think if I can do the math right, that's 3 minutes a trend. So somebody in the audience will keep me honest to cover a $3 trillion industry at 3 minutes a trend. So where are we today? Why are we here, and why are we seeing the activity that's happening? I think the popular press likes to talk about what's changing in healthcare as a response to regulation. I like to think we got to the point where regulation happened because of the fundamental changing economics of healthcare, and that regulation was one of many reactions that helped to move a lot of things forward. But the kind of activity we're seeing is really a result in the shift in how the business of healthcare is working, and in the fact that we've finally gotten to that point where the economics are unsustainable the way they work. Now, what did regulation do? Regulation did a couple of things, and these numbers are really kind of staggering to me. What the ACA has done is taken 30% of the total profit dollars out of the traditional health insurance and admin business. So let that sink in for just a second. If I model the industry, if I do a P&L for the industry, not for a given player, and I look at the piece that we think of as the traditional insurance business, 30% of the profit dollars have come out of that. So what does that mean if I'm a health insurer? If I'm a health insurer, what that means is I need to get bigger. I need to get my cost structure down. I need to find a better way to play in this scale business. Or I need to find new lines of business, like every regulated industry has over time. If I'm a cable company, I got into internet. If I'm a telephone company, I got into something else until wireless showed up. And if I'm a health insurer, I'm looking at getting into enablement businesses, the Optums and Healthagens of the world. I'm looking at investing in ways and engaging with providers. I'm looking at becoming a provider. I'm looking at all sorts of other things that require scale. I think what else has happened on the other side of this is there have been clear winners and losers. So we talk a lot about the consolidation happening at the national level. It gets all of the headlines, and I think all of us gets worked up. 35 of 36 Blues plans in this country in 2014 had a negative operating margin. 35 out of 36. Now, many of them had a positive net income. It was a good investment market. They did well there. They had some ancillary services. But if I look at the core underwriting margin of their businesses, 35 out of 36 of them lost money. So the chart on the left-hand side gives you a sense of what's really happening. The top one are the national and large plans. They're losing margin, but they're maintaining at least profitability. The Blues in aggregate are making some, but it's declining very quickly. But in those Blues are increasingly players that look like national plans, right? They're the Anthems of the world. I picked one example because it's easy to see what's going on, and I didn't want to offend anybody in this room. So this is Blue Cross Blue Shield of North Carolina on the bottom, right? And that's what happened to their operating margin. But we could tell that story around the country when I look at the independent plans. The other thing that's happening is scale economics in this business are changing. And this is, I think, where the providers come into play. We're now seeing a world that's splitting into really 2 types of scale. National scale is all about the admin business. As lives move into self-insured, fundamentally what it is to be a health plan is to be a BPO organization, to be an outsourcing organization. You're processing claims, you're running information, you're answering phones, and the scale curve on that works even at the very large end. So you can see the case for the deals that we're seeing on the health plan side. What we see is that there's about an 80% scale cost curve in this. So if I double my membership, I get 20% of the costs out of admin, right? And that works even at the very large end. And that's part of the impetus for what we're seeing here. The other side, though, is we're still in a negotiated market, and I think this is where providers come into play. The other piece of scale that really matters is local market scale. And so the smart players have maps of the country, and what I'm looking at is the delta between the market share of the largest providers and the market share of the largest payers. And I can tell you who's profitable based on that difference. Full stop, right? I can tell you who's profitable based on that difference. The challenge is that game has stopped working in the provider world, because that game only worked in the old Robin Hood business. And the Robin Hood business of healthcare was, I make 40 cents on the dollar on employer-sponsored care. If I'm really good and do really smart things, I can get close to break even on Medicare, and I give 38 cents out the back door for everything else. What happens when 25 million lives shift? Which is what's happened. And that's what's happened on the provider side. So it's a complicated chart that we had a lot of fun drawing. May not be as fun to look at. But the orange bubbles are 2014 to 2015, where membership decreased in this country. And the green bubbles are where membership increased, right? Total country. Here's the challenge. There's 25 million lives that moved year over year across these bubbles, from the orange to the green. If I'm a health plan, this is terrifying, right? If I'm a health plan, they all moved into less profitable parts of my business. They all moved into games I don't remember how to play anymore. They all moved into places where I'm going to get reimbursed for outcomes, and that's a different business. Now, if I'm a provider, this feels good for a little while, and we've seen this, because there's a lot of uninsured where I lost a lot of money moving into Medicaid, and the individual market where I lose a little less money. And net, that's a good thing across the country, and it's actually what's provided some of the capital and spurred some of the consolidation that we've seen. But that's not what happens next. That settles out, and then we start losing the Robin Hood game, right? Then we start losing the game. And so the consolidation we're seeing in the provider side is, one, about negotiating power, but the smart providers are saying, I've got to consolidate because I can no longer negotiate my way to profitability. I've got to consolidate because healthcare just became an information business. The way I'm going to make money is by knowing how to get utilization down. The way I'm going to make money is by having a bigger risk pool of a very small population that I can learn how to treat and care for and recruit for and develop the care models for. I need to be big enough that I can have a marketing strategy for a segment that I care about, right? And that's the next round that we start to see. It's no longer just consolidating to get more negotiating power, right? It's a different kind of consolidation. It's a different kind of scale business. And so I think that leads us to, well, who else gets good at those businesses? Because the game just changed. The competition just changed. Because we now have a lot of industries out there. Small startups where $6 billion in VC funding went into digital health last year. And giant companies, whether they're the Googles or the Apples or the Walmarts of the world, saying, I know how to win in an information business. You know what a scale information business is. It's not what not-for-profit providers are trying to learn and completely change. It's not what health insurers are trying to learn, because outsourcing and information are two very different things. It's what I've done all along. It's what I've done all along. And they've discovered that the best way to experiment is to cherry-pick those Robin Hood economics. And so if I search on Google now for a certain set of conditions in certain areas of the country, it'll actually offer me a free telemedicine visit. Honest to God. I was down at Facebook the other day, and they can predict 3 days out, based on status updates and Facebook activity, a schizophrenic episode. Right? Think about that for a second. Right? They know they can do it. They have seen it, and they are showing it, and they are testing it. Right? They say, we've got information about the other 23 and a half hours of somebody's life, right, that they're not seeing a healthcare provider. And what they say is, we're in the power position. Who are we going to sell that info to? Right? Who's bearing the risk, and who actually wants that, and who's going to write the check? So this is the kind of thing we see. I think we talk a lot about consumer tech and tech-enabled ecosystems, and it sounds a lot like stuff white people like, right? It's all apps, right? It's all things that say we're just going to take people who get good care today and get them slightly better or more convenient care, right? Or I'm going to take old fee-for-service medicine and put it in a nicer waiting room and maybe add telemedicine on the front of it, the last thing. But the real information innovations are saying, how do I now know something about people who don't come in? And those are the ones driving the cost, right? Those are the ones driving the cost, and they're the kinds of things we start to see. Most of these things will fail. Bob was telling me that he's gotten to a point in life where he doesn't buy green bananas, so he doesn't invest in venture capital anymore, because he doesn't have a 10-year time horizon. But one... you told me that. So which of these thousands is going to work? Which of these is going to hook? I don't know. But we have some of the very richest companies in the history of the world who have a lot of cash to go out and experiment on this stuff. And when 1 out of every $5 flows through this, they think this is information that matters. And they're trying really hard. Oh, there we go. The other piece is risk is shifting. And I think there's a lot of eye rolling that even I've done about the kind of shift to risk and the shift to value, so-called. And we talk about these numbers that HHS is out saying that they're going to tie half of payments to quality by 2018. We have all of these contracts going out. The risk has not come out of the system. We're moving it from one player to the other. I like to think of this as fundamentally changing the supply chain of healthcare. Right? What this is saying is that what we value is not the operational piece, but what we value is the management piece, the risk management piece of this business. And that really fundamentally changes how you run the business. What that says is all of the things that we have done for years and years, which is to take the business and silo it, which is to take the business and lean it out, which is to design things for the convenience of those delivering it and get unit costs down just a little bit, is not actually what matters. And I think the kind of collaboration we're going to need to see to make this work is different than what we've seen in the past. The past kind of payer and provider and innovator and doctor collaboration is like peanut butter and jelly, right? It's better together. I still know the peanut butter and jelly is there, right? What we need now is mayonnaise, right? What I need now is to take an egg and take the oil and have something looks completely different coming out of it. And so the smart players in this space are thinking about, how do I describe the healthcare system the way consumers would describe it? And we do this research with consumers all the time. We brought a bunch of consumers across the country into our offices and said, draw out on a giant piece of paper all the contact points you have with the healthcare system over the course of the year. Can anybody guess how many they drew? It's an open-ended question. We fed them, so it gets them to stay. So they drew over 100. The average person drew over 100, which just floored me. And what they drew were getting an EOB in the mail, benefits enrollment at work, going to see their mom in assisted living, picking up a prescription, calling to make an appointment, having a procedure, going on WebMD to research a condition they think they might have, and on and on and on. And then we asked them to take those and circle what parts were the most broken, where were their biggest hassles. And then we asked them, of those, so there were 60 some odd unique ones you could find across all of those, who was responsible for them. They got it wrong more often than they got it right. They blamed the health insurer for the benefit design their employer picked. They blamed their doctor when their prescription wasn't ready. They blamed the pharmacist when they had side effects from their drugs. I mean, honest to God, they got it wrong more often than they got it right. And that tells us something about what value and consumerism really mean. It doesn't mean peanut butter and jelly. It means they view the world in watercolor, and it's our job to make the experience better. That's how they want to engage, right? And we all know this intuitively. Nobody's ever had cancer or had a friend who has cancer and said, how's your experience? And they said, B+ on the infusion center. The oncologist is kind of an A-. You know, I really hate my insurer, but that WebMD is pretty cool, right? That's not how they talk. It's, I'm getting good care and it's going okay and I'm surviving or I'm not, right? That's how they think about it. And that's the kind of collaboration we've got to start to see. And so we kind of wrote this up. This is a little stylized version because I was sort of tired of putting survey numbers up. But if you squint a little bit, this is what we actually heard from the consumers in the research. When you expose them to real transparency about what healthcare costs, they think it's overpriced by about 40%. If you said you had to, what's it worth to you, and then here's what your insurer really paid for it, it's about 40% off, right, if it was their own money. It's why we've had so much trouble for 23 years with consumer-directed healthcare. Because all they do is bring their utilization down. They don't think they don't shop. They don't think any of it's worth the money. Right? They don't think even the cheap ones are worth the money. They want a better experience. They want it to be where they are, and they don't want us to do segmentation based on their condition, because that's not how any other industry works with them, how any other industry talks to them. Nobody shows up at a cocktail party and says, I'm a diabetic, right? They talk about who they are, and so they want to be able to go for chronic care in an intensive model, and when they have a sick kid in the middle of the night, to call somebody on the phone, and when they need a work physical, to go to a retail clinic, and they want it all to connect, and they want it to work. And that sounds preposterous, but it's how their bank treats them, right? I can get my balance at my ATM or at my branch or online, and I don't buy a plan that only gives me one of those, right? I go between places. It's this kind of experience, and they tell us that time and time and time again. So what does it mean? There is a real new normal that all this consolidation leads to, and I think my colleagues are going to talk about, which is we have to reinvent the business models. The regional players are going to shrink or grow, but they're not going to survive where they are, and that's true in the payer side and the provider side. You know, one of the most stunning numbers I've seen is 30 years ago, there were over 100 regional Blues plans. Today, there's 36. Where's the next wave? Where's the next wave in that, right? That's these scale economics. We've got to reinvent this supply chain, right? We've got a supply chain that has left the consumer and the patient to assemble all the pieces. You know, we are not delivering solutions. We're delivering piece parts that sometimes we give them instructions for how to fit together. And we did that because we wanted to take unit cost out, and it's not what they want, and it's not how they're going to engage. Right? We are seeing an ever-widening gap between consumer perceptions of providers and payers. Payers of 143 industries on average have the lowest consumer perception in the country. The cable companies beat them by 2 places, right? Providers in most markets, at least the quote-unquote good ones, are in the upper quartile. And I think this is the #1 reason we're going to see some of these provider-sponsored health plans survive. Because in the individual market where that brand matters and that affinity matters, as brand matters more, it advantages providers unless health plans figure it out, right? And so NPS becomes an EPS measure. It's a line we stole, by the way. Steve Hemsley said that in a talk about 3 months ago for United Health Group. We're going to see these new competitors, and we're going to see some of the money shift. We're going to see a lot of the money shift. There's $3 trillion that we all like to talk about being spent in healthcare. The number that we don't talk about enough is there's another $1.5 trillion that people spend on things that affect their health that we don't count in the system, right? That's the weight loss and the advice and the vitamins and all the things they think they're doing that are good for them. 92% of that spending is ineffective from a health outcomes perspective, but they think they're doing it. And the smart players aren't going to sit around and watch an industry shrink. What they're going to do is go after that $1.5 trillion to make them more profitable on the $3 trillion side. That's the way you connect that for people. So in sum, I'll hand it over. A lot of times when we share some of these findings, people look around and say, Sam, but really, right? You look at all of this and payer stocks are sky high, many of them. A lot of M&A activity, a lot of capital flowing in. Providers' systems are getting bigger, and EBITDA is actually pretty good for a lot of them right now, and they say, really? And I want to remind people of something that just a little over 20 years ago, that the Dow 30 included Eastman Kodak, Bethlehem Steel, Woolworth, and Sears Roebuck, right? Just a little over 20 years ago. And today it includes Merck and Pfizer and United Health Group. And I think there's some probably pretty good money that says those won't be the names in there in 20 years. And the question is which name's going to be up there. So we'll see what happens, but thank you very much.